Right now, in the mouths of literally millions of people, there is this silent, microscopic war being waged.
Yeah, it's a relentless chemical siege.
Exactly, a
Mm.
siege that literally eats away at the absolute hardest substance in the human body. And the wild part is, like, most of us are completely oblivious to it until a nerve gets exposed.
Right, or until a warning light flashes, in the form of a bleeding gum line.
Yeah, or far more tragically, a cellular checkpoint completely fails and a mass begins to grow.
It's an incredibly dynamic environment. I mean, the oral cavity and the upper gastrointestinal tract, they're the primary interfaces between the outside world and our internal biology.
Totally.
Every single day, that mucosal lining is battered by mechanical trauma, bathed in harsh acids, bombarded by foreign pathogens. It is quite literally a biological battleground.
And for you, the listener joining us today, understanding the rules of engagement on this battleground isn't just, some casual medical trivia. We know exactly why you are here.
Ye do.
You are staring down the barrel of a massive, life-altering board exam. Your graduation, your residency match, your future ability to look at a pathology slide and make a call that could literally save a patient's life. It all hinges on mastering this material.
So take a deep breath. We are going to do the heavy lifting with you today.
Yes, we are. This deep dive is your ultimate, fully integrated masterclass on upper GI and oral pathology.
We're merging the dense mechanistic depth of your core pathology texts. Think Robbins with the high-yield, rapid-fire synthesis you need for exam day, like first aid.
Haha. Because we're not just going to sit here and read you a list of flashcards.
No, absolutely not. Rote memorization shatters the second a question stem introduces a twist. To pass, you must understand the underlying biological logic.
So we're going to trace the anatomy, right?
Mm-hmm.
Starting from the enamel of the teeth, moving into the soft tissues of the gums, mapping the mucosal lesions.
Right, all those devastating carcinomas of the mouth, the salivary glands, and finally riding the swallowing reflex down into the esophagus.
Okay, let's unpack this. We'll start at the physical vanguard, which is the teeth. We always hear the scolding from the dentist, sugar rots your teeth.
Which is such a classic phrase.
Right. But sugar isn't an acid. If I drop a tooth in a glass of sugar water, it doesn't, dissolve. So how does a sweet tooth actually translate into the physical breakdown of enamel? Let's walk through the exact step-by-step cascade of dental caries.
That distinction is actually the perfect starting point because it highlights a core principle of pathology, which is the difference between a trigger and a cascade.
Okay.
You're completely right. Sucrose itself doesn't melt enamel. The pathogenesis of a cavity is actually a bacterial fermentation cascade.
So the bacteria are the real culprits.
Exactly. The human oral cavity is teeming with commensal bacteria. The most notable one for your exam is Streptococcus mutans.
Streptococcus mutans. Got it.
So when you consume refined carbohydrates, those sugars pool in the crevices of your teeth. And the bacteria don't just sit there, They feast. They metabolize those sugars for their own energy.
And the byproduct of that bacterial feast is the actual weapon, right?
Yes. Through glycolysis and fermentation, these bacteria excrete organic acids, primarily lactic acid.
So it's the lactic acid.
Right. This local generation of acid causes the pH in that specific microenvironment to plummet. Now, enamel is mostly made of crystalline calcium phosphate, specifically hydroxyapatite.
Which is super hard.
It's the hardest substance we possess.
Yeah.
But it is highly vulnerable to an acidic environment. When the pH drops below roughly 5.5, the acid begins to pull calcium and phosphate ions right out of the crystal lattice.
Wow, it just yanks them out.
Yeah, that is focal demineralization.
It's literally leaching the minerals out of the armor. And this brings us to a massive testable public health intervention. We put fluoride in the drinking water, right? Dentists paint it on your teeth.
Right, a very common practice.
But if the mechanism of cavity is bacterial acid, how does fluoride actually stop it? I assume it's not just like poisoning the bacteria.
No, it acts on the physical chemistry of the tooth itself. When fluoride ions are introduced into the oral environment, they interact directly with the demineralized enamel.
Okay, how so?
The fluoride ion actually substitutes for the hydroxyl group in the hydroxyapatite crystal. It chemically alters the structure to form a completely new compound called fluoroapatite.
So it's essentially a biochemical armor upgrade.
Precisely. Fluoroapatite has a much tighter, more stable crystal lattice, and because of this structural change, it is significantly less soluble in acid.
Oh, I see.
Yeah, it actually lowers the critical pH required for demineralization down to about 4.5. You are forcing the bacteria to work exponentially harder to cause the same amount of structural damage.
That is fascinating.
Plus, fluoride actively promotes the remineralization process, drawing calcium and phosphate back into the tooth.
Okay, so that's the physical destruction of the hard structures. But let's shift our focus to the soft tissues holding those teeth in place, the gingiva or the gums.
This is a crucial transition.
Yeah, because this is where we encounter the great clinical divide between gingivitis and periodontitis. I always picture gingivitis as like the warning light on your car's dashboard.
That's a great way to think about it.
Right. It's red, it's flashing, your gums might bleed when you floss, but fundamentally, the engine block is still intact.
That's a very accurate clinical picture. Pathologically, gingivitis is just a localized, reversible inflammation of the squamous mucosa surrounding the teeth.
And the trigger here is plaque.
Exactly, the accumulation of dental plaque. But for the boards, you can't just think of plaque as like general gunk. You have to understand its microscopic composition.
What's actually in it?
Plaque is a highly organized, sticky biofilm. It's a structured matrix containing bacteria, salivary proteins, and desquamated epithelial cells, which are just the dead skin cells shedding off the inside of your mouth.
Gross. So it's a microscopic city built out of spit, dead cells, and microbes. And if you don't break up that city with a toothbrush, it fortifies its walls.
It mineralizes. Calcium and phosphate from your saliva precipitate into the plaque biofilm, and that hardens it into calculus, which patients usually know as tartar.
And once it's tartar, you can't just brush it away.
Right, brushing won't remove it. This hard, bacterial-laden mass sits right at or below the gum line, constantly aggravating the tissue. The immune system responds to this chronic bacterial presence by sending in inflammatory cells.
Which explains the clinical signs, right?
Yeah.
Erythema, because the blood vessels dilate. Edema, because fluid leaks into the tissues.
Yeah, and bleeding because those engorged vessels are incredibly fragile. But like you said, the saving grace of gingivitis is reversibility.
You get a professional cleaning, you start flossing, and the warning light turns off. The tissue heals.
But if that warning light is ignored for years, the inflammatory process doesn't just stay in the superficial mucosa, it breaches the underlying connective tissue.
And that's the point of no return.
Exactly. That is when you cross the threshold from reversible gingivitis into irreversible periodontitis.
So the engine actually starts falling apart.
Literally. Periodontitis is the active destruction of the deep supporting structures of the teeth. We're talking about the periodontal ligaments that act as shock absorbers, the cementum that covers the tooth root, and the alveolar bone of the jaw itself.
Wait, hold on. Did the bacteria actually eat the bone? How does the jawbone just dissolve away?
It's actually a tragic irony of immunology. The bacteria don't eat the bone. Our own immune system destroys it.
Seriously.
Yes. As the plaque grows down the root of the tooth, it forms deep subgingival pockets. The bacteria release toxins and enzymes, and our macrophages rush in to fight them.
Okay, that makes sense.
But these macrophages release pro-inflammatory cytokines, specifically interleukin-1 and tumor necrosis factor, or TNF. And these cytokines do something devastating.
What do they do?
They stimulate osteoclasts.
Wow. So our immune system, in this panicked attempt to eradicate the bacterial invasion, activates our own bone-resorting cells. We burn down our own foundation just to spite the enemy?
That is exactly what happens. The osteoclasts dissolve the alveolar bone, the periodontal ligaments detach, the pocket deepens even further, and eventually the tooth loses its anchor and just falls out.
That is terrifying.
It is. But from an exam perspective, the most critical concept here is the microbial shift. You absolutely must know how the bacterial flora changes as this disease progresses.
Right, because the environment changes. A healthy, shallow gum line has access to oxygen. So simple gingivitis is mostly driven by facultative gram-positive organisms that tolerate air.
But as that pocket deepens down the root, the oxygen gets cut off. It becomes this dark anaerobic trench.
Which creates selective pressure, right?
Yes. The oxygen-loving bacteria die off, and a highly aggressive cohort of anaerobic and microaerophilic gram-negative bacteria takes over.
Okay, so this is a classic board scenario. A patient presents with tooth mobility, deep periodontal pockets, severe bone loss on X-ray. You need to know the specific culprits.
You do. You have to be able to spot them in a lineup.
Let's name the heavy hitters, and I know they are absolute tongue twisters.
They really are. The three high-yield species you must recognize are Aggregatibacter actinomycetum commentans, Porphyromonas gingivalis, and Prevotella intermedia.
Aggregatibacter actinomycetum commentans. If you see that Latin mouthful, or Porphyromonas gingivalis, you immediately lock in on severe destructive periodontitis and anaerobic gram-negative pathogenesis.
Perfect. That covers the hard structures and their immediate anchors. Now we need to move off the teeth entirely and explore the mucosal lining of the rest of the oral cavity, the inner cheeks, the tongue, the palate, the floor of the mouth.
This is where diagnostic ambiguity really sets in for a lot of students. When a patient opens their mouth and we see a lesion, an ulcer, a bump, a white patch, we have to immediately triage.
Right, you have to ask yourself, is this a passing annoyance, an infectious disease, a benign reaction, or the early stages of a lethal carcinoma?
Exactly. So let's start with the most common painful nuisance, aphthous ulcers, commonly known as canker sores.
These are incredibly prevalent. They affect up to 40% of the population. They are superficial, but incredibly painful mucosal ulcerations.
So if we are looking at this in a clinical vignette, what is the gross pathology? Like, what is the visual red flag that differentiates an aphthous ulcer from something else?
The classic description is a shallow ulcer with a grayish-yellow hyperemic base.
Okay, a grayish-yellow base.
Yeah, that base is actually a fibrinopurulent exudate, a mixture of fibrin proteins and dead neutrophils. But the absolute diagnostic hallmark is what surrounds it.
Which is?
A narrow, sharply demarcated zone of intense erythema, a bright red halo.
A gray crater with a bright red halo, and they usually resolve spontaneously in a week or two,
Yeah,
right?
usually, yes.
But why do they happen? If a test asks for the underlying systemic association, where do we look?
Well, most cases are idiopathic or just triggered by stress. Severe and recurrent aphthous ulcers have a really powerful, testable link to systemic autoimmune and inflammatory conditions.
Oh, interesting. What's the mechanism?
The underlying mechanism is thought to be T-cell-mediated autoimmunity, where the body's immune system cross-reacts with the oral mucosa.
So if you have a patient plagued by these, what else should be on your differential?
You must broaden your differential to include celiac disease, inflammatory bowel diseases like Crohn's or ulcerative colitis, and Behçet disease.
Behçet disease. That's the triad of recurrent oral ulcers, genital ulcers, and uveitis, right?
Exactly. It's a vasculitis, but it often shows up first in the mouth.
Okay, so red halo ulcer, think immune dysregulation. Let's contrast that with another incredibly common ulcerating disease, but one driven by a virus, herpes simplex virus, or HSV.
For HSV, you really have to mentally separate the timeline into the primary infection and the reactivation phase. Most orofacial herpes is caused by HSV-1.
And the primary infection almost always occurs in childhood, right?
Yeah.
Usually between 2 and 4 years of age.
That's right. And while it can be asymptomatic when it flares up in a toddler, it is a diffuse nightmare called acute herpetic gingivostomatitis.
Yeah, the child will have an abrupt onset of fever, swollen lymph nodes, and just clusters of vesicles that burst into painful ulcers absolutely everywhere. Lips, gums, palate, tongue. They won't eat or drink because it hurts too much.
The clinical presentation is dramatic, but the key testable concept is that the virus isn't cleared when those ulcers heal. HSV is an absolute master of evasion.
Where does it go?
The virus enters the local sensory nerve endings in the mouth and utilizes retrograde axonal transport. It travels up the nerve fiber and establishes a lifelong latent infection in the trigeminal ganglion.
It just sleeps there, hidden from the immune system.
Exactly, until the host's defenses drop.
What triggers the virus to wake up and travel back down that nerve?
A myriad of stressors. Physical trauma, extreme temperature shifts, exposure to ultraviolet light, which is why people get cold sores after a day at the beach, allergies, upper respiratory infections.
Hormonal shifts too, right?
Yes, like menstruation. And importantly, any form of immunosuppression. When triggered, the virus replicates, uses enterograde transport back down the axon, and causes a localized cluster of vesicles, usually right at the vermilion border of the lip.
But the clinical picture, the vesicles on the lip, is only half the battle for your exam. You have to know what this looks like under the microscope.
Histology is paramount here.
Right. So if a pathologist biopsies the edge of a herpes vesicle, what is the cellular destruction pattern?
The histology of HSV is intensely testable. The virus causes highly specific cytopathic effects in the squamous epithelial cells.
Walk us through it.
First, the infected cells undergo ballooning degeneration. Because the virus hijacks the host's macromolecular machinery, the cell loses its osmotic regulation, swells up massively with fluid, and detaches from its neighbors.
So you have these cells inflating until they are ready to pop. And what about inside the nucleus?
That's where you find the smoking gun. You will see large eosinophilic, meaning they stain a bright, vivid pink intranuclear inclusions.
The eosinophilic intranuclear inclusions.
Yes. These are classically known as Cowdrey type A bodies. What you are actually looking at is a massive viral replication factory pushing the host cell's own chromatin outward against the nuclear membrane.
Ballooning cells with pink viral factories in the nucleus. There's one more classic cellular finding, right?
Yes, there is. The viral envelope contains fusion glycoproteins. These cause the cell membranes of adjacent infected cells to literally melt together.
So they combine.
Exactly. You end up with these massive, monstrous cells containing multiple nuclei. We call them multinucleated giant cells, or polykaryons.
So if a vignette describes ballooning degeneration, eosinophilic intranuclear inclusions, and multinucleated giant cells, you just slam the button for HSV.
100%.
Incredible. Okay, we've covered the ulcers. Now we step into one of the most vital clinical scenarios in all of dentistry and ENT medicine, the white and red plaques.
This is a massive topic.
It really is. If you look in a patient's mouth and see a prominent white patch on the tongue or inner cheek, you are instantly faced with a huge differential. Is it an opportunistic fungal infection, or is it a precancerous lesion? Let's dissect oral candidiasis, or thrush, versus leukoplakia.
Let's start with the fungus. Candida albicans is actually a normal, harmless component of the oral flora in up to 50% of the population.
So why does it suddenly cause a problem?
Because it is an opportunistic pathogen. It only shifts from a harmless neighbor to a tissue-invading disease when the local microenvironment changes.
What causes that shift?
The most common trigger, and a huge exam favorite, is the use of broad-spectrum antibiotics.
Right, because if a patient takes a heavy dose of, say, amoxicillin, it wipes out the normal bacterial flora.
Exactly. And without those competing bacteria, the ecological niche is suddenly empty. The fungus, which isn't affected by antibacterial drugs at all, overgrows massively.
That makes perfect sense. What's the other major trigger?
Immunosuppression. We see severe thrush in patients with uncontrolled diabetes, patients on chemotherapy, transplant recipients on immunosuppressants, and classically, patients with advanced HIV or AIDS.
Clinically, thrush presents as a superficial, curd-like, gray-to-white inflammatory membrane. It literally looks like someone smeared cottage cheese on the buccal mucosa.
That's the perfect visual.
But you can't just diagnose it by looking at it, right? You have to perform a physical maneuver to confirm it.
Yes, the scrape test. This is the ultimate diagnostic differentiator for your exam. If you take a tongue depressor or a piece of gauze and wipe it firmly across the white patch, thrush will scrape off.
It's like scraping moss off a brick. Why does it detach so easily?
Because it's not actual tissue. That white cottage cheese is a pseudomembrane. It's just a matted, tangled web of fungal hyphae, dead epithelial cells, and inflammatory exudate sitting on top of the mucosa.
Ah, so it's not anchored in.
Right. When you scrape it away, you reveal the underlying intact mucosal surface, which will be deeply erythematous and raw, but the white mass itself is easily removed.
So you do the scrape test. The white stuff comes off on your gauze, and you exhale. It's fungal. You prescribe nystatin or fluconazole.
Simple as that.
But what happens if you scrape it and it doesn't budge? What if that white patch is firmly anchored to the underlying tissue?
That is the moment your clinical suspicion must pivot immediately to malignancy. If a white plaque cannot be scraped off, it is clinically defined as leukoplakia.
And that's a dangerous word.
Very. You must consider it a precancerous lesion until proven otherwise by a biopsy.
Let's explain the pathophysiology of leukoplakia. Why is it white and why doesn't it scrape off?
Well, leukoplakia literally translates to white plaque. The reason it won't scrape off is because it is not a superficial membrane. It is an actual physical alteration of the epithelium itself.
How does the epithelium alter?
The squamous cells undergo a process called hyperkeratosis. In response to a chronic irritant, most often tobacco smoke or chewing tobacco, the mucosal lining tries to build a shield.
A shield out of what?
Keratin. It drastically thickens its stratum corneum, producing layers of dense white keratin.
So the body is essentially building a thick callus to protect itself from the carcinogens. But I'm guessing that defensive mechanism goes awry.
Exactly. While hyperkeratosis itself is just a thickening, the cellular machinery regulating growth often becomes corrupted by the carcinogens. Histologically, roughly 5 to 25% of these leukoplakias are dysplastic.
Let's define dysplasia clearly for the listener because it's a critical concept.
Dysplasia is disordered growth. When a pathologist looks at dysplastic tissue, they see cells that have basically forgotten how to behave.
What does that look like on the slide?
The cells show architectural and cytological atypia. They have enlarged dark nuclei, which we call hyperchromasia. They vary wildly in size and shape, which is pleomorphism, and they completely lose their normal maturation sequence from the basal layer to the surface.
So you're actively walking down the path toward becoming invasive cancer.
Yes, they are.
So any white plaque that doesn't scrape off gets a scalpel taken to it for a biopsy. But there's a lesion that is even more terrifying than leukoplakia, erythroplakia.
Erythroplakia is a red, velvety, completely flat, or sometimes slightly depressed mucosal lesion. It is much less common than the white plaques, but its malignant potential is staggering.
Why is it red? If leukoplakia is white because of thick keratin, what makes erythroplakia so profoundly vascular looking?
It's red because the epithelium has fundamentally failed. In erythroplakia, the cells are so profoundly dysplastic that they completely lose the ability to produce that protective keratin layer at all.
So the shield is gone.
Completely. The epithelial lining becomes incredibly thin and disorganized. Because the opaque keratin is gone, you are looking directly at the underlying subepithelial blood vessels shining right through the thinned-out tissue.
It's essentially an open window into the vascular bed because the cellular roof is caved in. And the statistics on this are chilling.
Extremely chilling. The malignant transformation rate for erythroplakia is greater than 50%.
More than half.
Yes. More than half of these red velvety patches already harbor severe dysplasia, carcinoma in situ, or frankly invasive squamous cell carcinoma at the exact time they are discovered.
So let's submit the red-white rule for the exam. White that scrapes easily, candida. White that stays stuck, leukoplakia, which is a protective hyperkeratosis hiding potential dysplasia.
And red, velvety, and flat. Erythroplakia, a thinned-out, highly dysplastic lesion that is a massive red flag for imminent cancer. And remember, both of those latter plaques are deeply tied to tobacco use.
Okay, now let's pivot from flat plaques to three-dimensional masses. We need to distinguish between benign reactive lumps and malignant tumors. If a patient comes in complaining of a bump on their gum or inner cheek, how do we evaluate the stromal proliferative lesions?
The two high-yield benign masses you need to master here are the fibroma and the pyogenic granuloma.
I like to think of the fibroma as the ultimate reactive callus of the mouth. This isn't a neoplasm, right? It's a mechanical defense mechanism gone into overdrive.
That analogy perfectly captures the pathogenesis. A fibroma doesn't just spontaneously generate, it is triggered by chronic, repetitive irritation.
Like what?
Imagine a patient who has a nervous habit of constantly biting the inside of their buccal mucosa along the occlusal line, or an elderly patient whose dentures constantly rub against their gingiva.
So the tissue realizes it's being repeatedly traumatized, so it mounts a defense to pad the area.
Yes, the chronic trauma activates local fibroblasts. These fibroblasts just start pumping out massive amounts of mature collagen. You end up with a reactive connective tissue hyperplasia.
And clinically, what does that look like?
You see a smooth submucosal nodular fibrous mass. Under the microscope, it is remarkably boring, just dense, mature collagen bundles covered by normal squamous epithelium.
So it's entirely benign.
Entirely. You surgically excise it, but more importantly, you must remove the source of the irritation or it will just grow back.
Simple, mechanical, benign. But the other mass, the pyogenic granuloma, is a legendary trap on board exams. I want to challenge the very name of this disease.
Please do, because it's awful.
Pyogenic literally means pus-producing. Granuloma implies a specific immunologic structure involving macrophages and giant cells, like we see in tuberculosis. So, is a pyogenic granuloma a pus-filled bacterial abscess surrounded by macrophages?
No, and that is exactly why they test it. The name is a complete historical misnomer. A pyogenic granuloma is not pyogenic. It produces zero pus, and it is not a true granuloma in any histologic sense.
It is a master of disguise. So what is the actual biology of this mass?
It is an inflammatory vascular proliferation. It is a localized, explosive overgrowth of blood vessels.
Where do we typically see this, and who gets it?
They almost always pop up on the gingiva. They are very common in children and young adults, but the classic board presentation is a pregnant woman.
Ah, pregnancy tumors.
Exactly.
Yeah.
They are so heavily associated with the hormonal shifts of pregnancy. The massive surge in estrogen and progesterone, along with an upregulation of vascular endothelial growth factor, or VEGF, causes the capillaries in the gums to hyperproliferate in response to even mild local irritation, like plaque.
Because it is literally a knot of new blood vessels, the gross appearance is alarming. It's a rapidly growing exophytic mass, meaning it bulges outward.
Right, and it's bright red or deep purple.
And because those new vessels are incredibly fragile and lack structural integrity, it ulcerates and bleeds profusely if you so much as touch it with a toothbrush.
The rapid growth and the bleeding are what terrify patients and inexperienced clinicians. They mimic malignant vascular neoplasms. But the histology tells the true story.
What do you see on the slide?
If you put a slice of this under a microscope, you do not see malignant pleomorphic cells. You see a distinct proliferation of immature capillaries and endothelial cells, separated by an edematous stroma teeming with inflammatory cells.
It looks exactly like standard granulation tissue, the same tissue your body builds to fill in a deep skin cut.
Exactly. It's just an exuberant, localized healing response that got wildly out of control. Over time, if left alone, they can spontaneously regress, especially after pregnancy ends, or they might fibrose and harden into a standard fibroma. But definitively, conservative surgical excision is the cure.
Excellent. So fibroma equals fibrous collagen from biting. Pyogenic granuloma equals rapidly growing bleeding vascular tangle driven by hormones and inflammation.
That's the perfect summary.
Which brings us to the most critical, high-stakes topic of this entire deep dive. This is where our understanding of pathology literally dictates patient survival. We're transitioning to malignant neoplasms.
Yes, we need to comprehensively master oral squamous cell carcinoma, or SCC.
Squamous cell carcinoma is the undisputed heavyweight of oral pathology, right?
Yeah.
It accounts for roughly 95% of all cancers of the oral cavity.
It does. It is an aggressive, destructive epithelial malignancy. But what makes oral SCC so fascinating and so incredibly testable is that there are two completely distinct pathogenic pathways that lead to the exact same histologic cancer.
Two totally different origins, different genetics, different anatomical locations, and surprisingly, different survival rates. Let's dissect pathway 1, the carcinogen or tobacco pathway.
This is the historical classic pathway. The mechanism here is chronic, relentless exposure to chemical carcinogens. In Western nations, this is primarily driven by the synergistic, destructive combination of alcohol abuse and smoked or chewed tobacco.
And globally.
In other parts of the world, specifically India and Southeast Asia, a massive driver is the chewing of betel nuts and leaves, known as primation.
We mentioned earlier that these chemicals cause the cells to hyperkeratinize and become dysplastic leukoplakias.
Yeah.
But what is the actual molecular damage? How does a chemical in a cigarette turn a normal squamous cell into a malignant tumor?
The chemicals, like benzopyrene in tobacco smoke, form direct DNA adducts. They physically damage the genetic code. Over decades of exposure, the cells accumulate a massive mutational burden.
What are the specific genetic failures we need to know?
For your exam, you need to know 3 specific genetic failures that define this pathway. First and foremost, mutations in TP53.
The guardian of the genome.
Exactly. TP53 normally acts as the ultimate tumor suppressor. If a cell's DNA is damaged beyond repair, P53 halts the cell cycle and triggers apoptosis. It forces the damaged cell to commit suicide.
But in these tumors, the carcinogens mutate and deactivate TP53. The guardian goes offline, and severely mutated cells are allowed to survive and divide.
Yes, the brakes are cut. Next, you have mutations in the RAS family of genes. RAS proteins are signaling molecules that regulate cellular proliferation.
And when they mutate,
When mutated, they become permanently stuck in the on position, constantly telling the cell to divide. So now the cell has no brakes and the accelerator is glued to the floor.
that's a lethal combination. Is there a third one?
Finally, you see mutations in genes like NOTCH1, which normally regulate squamous differentiation.
So the cell loses its ability to mature into a normal, flat, protective squamous cell. It just stays in an immature, rapidly dividing state. Clinically, where do these chemical-driven tumors physically show up in the mouth?
Well, because gravity and saliva cause the carcinogens to pool in the lower areas of the mouth, these tumors typically arise in the ventral surface of the tongue, the underside, the floor of the mouth, the lower lip, and the gingiva.
They often begin as those dysplastic leukoplakias, or erythroplakias we discussed, eventually progressing into raised, firm, pearly plaques or ulcerated masses with rolled borders.
Yes. But the most terrifying concept associated with this tobacco pathway is a phenomenon known as field cancerization.
Can you explain this for the listener? It's such a huge concept.
Field cancerization fundamentally alters how we view surgical cures. The concept is that the patient hasn't just exposed one single cell to tobacco smoke. They have bathed their entire mucosal field in carcinogens for 20 or 30 years.
So every single cell in the mouth has been swimming in a mutagenic soup.
Precisely. As a result, multiple independent neoplastic clones are developing simultaneously all over the oral cavity. Even the tissue that looks completely normal to the naked eye already harbors silent TP53 and RAS mutations.
Meaning if an oral surgeon goes in, completely excises a tumor on the floor of the mouth, and gets perfectly clean margins, the patient isn't truly out of the woods.
Not at all. A year later, a completely new, independent tumor might erupt on the tongue, arising from a different mutated clone in that same cancerized field. Patients with tobacco-associated SCC have a profoundly elevated risk for developing second primary tumors.
It is a devastating reality of the disease.
Okay, let's completely shift gears and examine pathway 2, the HPV-related pathway. This pathway has seen a dramatic epidemiological rise over the last few decades.
It has, and the trigger here is not a chemical carcinogen over decades. It is an infectious virus.
Specifically, exposure to high-risk variants of the human papillomavirus, overwhelmingly HPV-16, typically transmitted via orogenital sexual contact. The molecular mechanism by which HPV causes cancer is elegant, sinister, and absolutely guaranteed to be on your exam.
Let's get into it.
The virus doesn't cause widespread random DNA damage like tobacco. It performs a targeted assassination of the cell's regulatory machinery using two viral oncoproteins, E6 and E7.
Let's break down the exact molecular sabotage. The virus infects the basal squamous cell and starts pumping out E6 and E7. What does E6 do?
The viral oncoprotein E6 specifically targets the host's p53 tumor suppressor, but it doesn't just block it. E6 recruits a cellular ubiquitin ligase.
And ubiquitin is basically a tag, right?
It physically tags the p53 protein with ubiquitin, which is the cell's signal for garbage disposal. The cell's own proteasomes then shred and destroy the p53.
Oh, wow. So E6 tricks the cell into executing its own genome guardian. That is brilliant and terrifying. What about E7?
E7 targets the other major cell cycle regulator, the retinoblastoma protein, or RB. Normally, RB binds to and inhibits a transcription factor called E2F, preventing the cell from entering the S phase of DNA synthesis.
So RB holds E2F hostage to stop division.
Exactly. E7 binds to RB, changes its shape, and forces it to release E2F.
And once E2F is suddenly free, it rushes to the nucleus, and it forcefully drives the cell into unchecked proliferation.
You've got it. So E6 destroys p53. E7 inactivates RB. Now, here is the crucial diagnostic twist. Because RB is incapacitated and the cell is being forced to divide, the cell panics.
It knows something is wrong.
Yes. It tries to throw the emergency brake by massively overexpressing another regulatory protein called P16.
Ah, P16. This is the high-yield biomarker, isn't it?
It is the absolute key. When a pathologist looks at an oral SCC biopsy and applies an immunohistochemical stain for P16, a massive overexpression of P16 serves as a highly reliable surrogate marker telling them this is an HPV-driven tumor.
And the tobacco-driven tumors do not overexpress P16.
Correct. They do not.
Geographically, where do these viral tumors hide? Because they aren't bathing in pooled carcinogens on the floor of the mouth.
HPV has a specific tropism for reticulated epithelium. Therefore, these tumors almost exclusively arise in the posterior oropharynx, specifically deep within the tonsillar crypts or at the base of the tongue.
So my mental map. The tobacco tumors are in the front and floor of the mouth, surrounded by a cancerized field of genetically shattered cells. The HPV tumors hide in the back, in the tonsillar crypts, driven by a targeted viral hijacking via E6 and E7.
And here is the counterintuitive clinical twist that you must understand for your exams. I want you to challenge this logic. If HPV systematically destroys our two most important tumor suppressors, P53 and RB, shouldn't these be the most lethal, untreatable tumors imaginable?
You would absolutely think so. It sounds like an unstoppable malignancy. But the data says the opposite, right?
Yes, HPV-positive tumors actually have a significantly better prognosis and higher survival rates than the HPV-negative tobacco-associated tumors.
Why is that?
It comes down to the overall genetic landscape. A tobacco tumor has decades of chaotic, widespread chromosomal damage. It has mutated countless pathways, making it highly resistant to therapy.
Whereas the HPV tumor.
An HPV tumor relies almost entirely on E6 and E7 to stay malignant. The rest of its genome is actually relatively pristine. Furthermore, because the tumor is expressing foreign viral proteins, the patient's immune system is far more likely to recognize and attack it.
No, that makes sense.
Finally, they are exquisitely sensitive to radiation therapy. because, unlike tobacco tumors with mutated TP53 genes, HPV tumors still have a functional, though suppressed, wild-type TP53 gene that can actually be reactivated by intense radiation damage.
That is a phenomenal, deeply integrated biological concept.
Yeah.
Now, regardless of the pathway, if we look at SCC under a microscope, what is the histology?
It ranges on a spectrum of differentiation. A well-differentiated SCC will clearly look like squamous epithelium. You'll see classic features like prominent keratin pearls, which are whorls of pink keratin trapped deep in the tissue, and intercellular bridges connecting the malignant cells.
In a poorly differentiated one.
On the other extreme, an anaplastic, poorly differentiated tumor will just look like a chaotic sheet of highly atypical primitive cells that barely resemble squamous tissue at all.
And how do these oral cancers spread?
They are highly infiltrative locally, invading nerves and bone, but their primary route of metastasis is lymphatic. They spread early and aggressively to the regional cervical lymph nodes.
So if you are examining a patient with an oral ulcer and you palpate a rock-hard fixed lymph node in their neck, you must immediately suspect metastatic squamous cell carcinoma.
Without a doubt.
We have thoroughly conquered the mucosal lining. Let's shift our anatomy deeper. We're moving into section 5 of our deep dive, odontogenic lesions and salivary gland tumors.
Let's get into the jaw.
Yeah, we are going to look at the structures buried within the jawbone and the massive glandular networks that bathe the oral cavity in saliva. Let's tackle the jaw cysts first. These are odontogenic cysts, meaning they arise from the epithelial remnants of tooth development.
The boards love to test your ability to differentiate between the two most common cysts based entirely on their location and developmental history: the dentigerous cyst and the periapical cyst.
Let's break down the nomenclature. Dent means tooth. Gerous means bearing. Dentigerous.
Exactly. A dentigerous cyst is a developmental anomaly. It originates from a defect in the dental follicle, which is the sac of tissue that surrounds a developing tooth.
The fluid builds up.
Yes, fluid accumulates between the reduced enamel epithelium and the crown of the tooth. Therefore, a dentigerous cyst always forms around the crown of an unerupted, impacted tooth, most classically, the third molars, or wisdom teeth.
So you look at an x-ray, you see a horizontal wisdom tooth stuck in the jaw, and there is a massive, dark, fluid-filled halo surrounding just the crown.
Yes. And the treatment is curative. You just extract the tooth and the cyst together.
Contrast that with the periapical cyst. Peri means around. Apical means the apex, or the very tip of the tooth root.
A periapical cyst is inflammatory, not developmental. This is the end-stage consequence of a severe cavity.
Circling back to our cavity discussion.
Right. If dental caries erode completely through the enamel and dentin into the pulp chamber, the nerve dies. This pulpal necrosis breeds massive bacterial infection. The bacteria and their toxins travel all the way down the root canal and exit the tip of the root, the apical foramen, into the surrounding jawbone.
The bone gets infected, the immune system forms a periapical granuloma to wall it off.
And eventually, epithelial rests of molasses in the area are stimulated to proliferate, turning that inflammatory mass into a true fluid-filled cyst.
So dentigerous is developmental, around the crown of a tooth that never erupted. Periapical is inflammatory, at the root tip of a tooth that has been killed by a cavity.
Perfect distinction. Now, we must mention one jaw cyst that behaves more like a tumor, the odontogenic keratocyst, or OKC.
This one is aggressive. It occurs mostly in patients between 10 and 40 years old, typically in the posterior mandible. It grows rapidly, literally hollowing out the bone, and it has an incredibly high recurrence rate even after surgical curettage.
But the true board-testable concept here is the genetic linkage.
Let's hear it.
Odontogenic hair cysts often harbor loss-of-function mutations in the PTCH1 tumor suppressor gene. This is critical because PTCH1 is the primary regulator of the hedgehog signaling pathway.
And when PTCH1 is mutated,
the hedgehog pathway stays permanently active, driving cellular proliferation.
And this isn't just a sporadic mutation, right? PTCH1 mutations are the defining genetic hallmark of nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome.
Exactly. So if a vignette describes a 20-year-old patient who has multiple keratocysts in their jaw and they are presenting with numerous basal cell carcinomas on their skin, you immediately link those two phenomena via the PTCH1 mutation.
Moving from fluid-filled cysts to solid tumors of the jaw, you need to recognize ameloblastoma and odontoma.
An ameloblastoma arises from the odontogenic epithelium. It is benign but wildly locally invasive. It will literally chew through the jawbone if left unchecked.
And the histology is highly distinct.
It has a classic biphasic histologic pattern. You see islands or cysts lined by a basal layer of palisading columnar cells, meaning they line up perfectly parallel like a picket fence.
Palisading columnar cells.
Yes, and these columnar cells overlay a loose central network of star-shaped cells called the stellate reticulum. Palisading columnar cells over stellate reticulum equals a melloblastoma.
Got it. And an odontoma.
Odontoma is actually the most common type of odontogenic tumor, but is considered a hamartoma rather than a true neoplasm. It is just an extensive, chaotic, disorganized deposition of mature enamel and dentin.
It literally looks like a handful of malformed miniature teeth clustered together on an X-ray.
It really does. It's easily cured by local excision.
All right, let's leave the jawbone and enter the complex, multifaceted world of the salivary glands. You have three major pairs. The massive parotid glands sitting in front of the ears, the submandibular glands tucked under the jawline, and the sublingual glands under the tongue.
Plus, you have thousands of minor salivary glands scattered across the palate and buccal mucosa. Salivary gland pathology is notoriously diverse. They give rise to over 30 histologically distinct tumor types.
But you do not need to memorize all 30 for the exam. You need a heuristic. You need the rule of gland size.
This rule is pure gold for multiple choice questions.
It really is. What is the rule?
The rule is this. The likelihood that a salivary gland tumor is malignant is inversely proportional to the size of the gland it arises in.
I love the mnemonic for this. The smaller the gland, the grimmer the stand. Let's break down the clinical statistics.
The parotid gland is by far the largest salivary gland. Unsurprisingly, it produces the vast majority of tumors. Between 65 to 80% of all salivary neoplasms occur here. However, the saving grace is that only 15 to 30% of parotid tumors are malignant.
The overwhelming majority are benign, so a large mass in front of the ear is highly likely to be benign. Now we step down in size to the submandibular gland.
Here, the malignancy rate jumps. About 40% of tumors in the submandibular gland are malignant.
And when we get to the smallest glands, the sublingual glands under the tongue and the tiny minor glands scattered across the roof of the mouth.
The statistics invert entirely. In the sublingual and minor salivary glands, 70 to 90% of tumors are malignant.
Wow.
Yeah, if a patient presents with a nodule on their hard palate, your index of suspicion for a highly aggressive carcinoma must be at absolute maximum.
Why does this happen biologically? Why are the smaller glands more dangerous?
It's largely tied to the cellular composition. The large parotid is composed almost entirely of well-differentiated, mature, serous acinar cells.
And the minor glands.
They have a much higher concentration of mucus cells, ductal structures, and primitive stem cell niches that just have a much higher propensity for undifferentiated malignant transformation.
Let's discuss the specific tumors you will be tested on. The undisputed king of salivary pathology is the pleomorphic adenoma.
This single tumor accounts for about 60% of all parotid gland tumors. Let's decode the name. Adenoma signifies a benign tumor of glandular origin. Pleomorphic means having many forms.
And it earns that name when you look at it under the microscope. The gross pathology is usually a smooth, rounded, well-demarcated mass. But the histology is absolutely wild.
It is a biphasic tumor, meaning it has two entirely different tissue types growing together.
What are we actually looking at on the slide?
It looks like a surrealist painting. You see distinct epithelial elements, ductal cells and myoepithelial cells forming cords and cysts. But these epithelial structures are floating in a massive sea of mesenchyme-like background stroma.
And what's in that stroma?
This stroma can be mucosoid, which is mucoid and loose. It can be hyaline pink and glassy, and frequently it contains islands of mature chondroid tissue, which is cartilage. You can literally find bone tissue growing inside a salivary gland tumor.
Epithelial ducts floating in a sea of cartilage and bone. How is that even biologically possible? How does a salivary gland make bone?
It comes down to the neoplastic myoepithelial cells. These tumors often feature an overexpression of the PLEG1 transcription factor.
Okay, PLG1.
This drives the myoepithelial cells to behave like pluripotent stem cells. They don't just replicate, they differentiate into entirely different mesenchymal lineages, building cartilage and bone matrices right in the middle of the gland.
Clinically, how does a pleomorphic adenoma present?
The patient typically reports a slow-growing, completely painless, mobile, discrete mass, usually sitting right at the angle of the jaw, just in front of and below the earlobe.
If it's benign, the surgeon just pops it out, right? What is the actual clinical danger here?
The danger is the recurrence risk. which stems from its really insidious gross anatomy. While the tumor feels like a smooth encapsulated marble, it actually has microscopic, finger-like extensions that protrude through the capsule and into the surrounding normal parotid tissue.
Ah, so you can't just pluck it out.
Right. If a surgeon just performs a simple enucleation, meaning they just shell it out along the capsule line, they will invariably leave those microscopic fingers behind. Within a few years, those remnants will spawn multiple new tumors. It requires a wide surgical margin, often a superficial parotidectomy.
There is another, much darker danger if the patient is terrified of surgery and just ignores the light for a decade or two, correct?
Yes, there is. A pleomorphic adenoma is a ticking clock. If left in place for more than 15 to 20 years, it accumulates genetic mutations. There is an almost 10% chance it will undergo a sudden malignant transformation into a carcinoma ex pleomorphic adenoma.
What does that look like clinically?
A patient will come in and say, I've had this lump for 20 years, it never bothered me, but over the last 3 months, it doubled in size and my face went numb.
That numbness.
That numbness is the newly formed cancer actively invading the facial nerve. These are highly aggressive and often fatal.
Okay, that covers the benign heavyweight. Now, for the primary malignant one, mucoepidermoid carcinoma.
This is the most common primary malignant tumor of the salivary glands overall. While it occurs frequently in the carotid, it accounts for a massively disproportionate fraction of the tumors in the minor salivary glands.
What's the genetics on this one?
Genetically, it is often driven by a balanced chromosomal translocation, creating a MML2 fusion gene, which disrupts normal Notch signaling.
The name gives away the histology perfectly. Mucoepidermoid.
Exactly. When you look at the slide, you see cords, sheets, or cysts lined by a variable mixture of 3 distinct cell types. First, mucus-secreting cells, which look pale and swollen with mucin. Second, squamous cells, which are the epidermoid part of the name, showing keratinization. And third, intermediate cells.
What exactly is an intermediate cell?
It's a hybrid transitional cell. It looks structurally like a squamous basal cell, but if you look closely, its cytoplasm contains tiny vacuoles filled with mucin. It is caught between 2 differentiation pathways.
Clinically, unlike the well-encapsulated pleomorphic adenoma, these lack a well-defined capsule, right?
Correct. They are infiltrative, meaning they aggressively weave into the normal gland.
How do we determine the prognosis for a patient with mucoepidermoid carcinoma?
The prognosis relies almost entirely on the histologic grade assigned by the pathologist. A low-grade tumor is well differentiated. It is predominantly composed of large, mucin-filled cysts with very little cellular atypia. These behave indolently and have a 5-year survival rate over 90%.
And high grade.
A high-grade tumor is a different beast entirely. It is highly invasive, highly cellular, densely packed with pleomorphic squamous and intermediate cells, and produces very little mucin. The 5-year survival for high-grade drops to 50%.
Right, we have systematically conquered the oral cavity. Now we follow the anatomical continuity of the GI tract. Swallowing takes everything, the pathogens we inhale, the caustic acid from our stomach, the food we chew, the hot coffee we drink, and funnels it straight down a narrow muscular tube.
Welcome to esophageal pathology.
What are the high-yield, life-threatening conditions you must spot here? Let's begin with the catastrophic vascular and mechanical issues. Esophageal varices.
Esophageal varices are a striking example of how a disease in one organ can cause fatal complications in a completely different part of the body. Varices are a direct hemodynamic consequence of portal hypertension.
Let's map the plumbing to understand this. Blood flow returning from the entire GI tract doesn't go straight back to the heart. It gets routed to the liver via the portal vein.
Right. The liver acts as a massive filter, extracting nutrients and neutralizing toxins in a process called the first pass effect.
But if the architecture of the liver is severely scarred, most commonly due to cirrhosis from chronic alcohol abuse or viral hepatitis, or worldwide from schistosomiasis, that delicate vascular network inside the liver turns to concrete.
The blood physically cannot flow through the compressed sinusoids. The pressure backs up massively into the portal vein. That is portal hypertension.
The pressure exceeds 10 millimeters of mercury, and that massive volume of blood needs to find a way back to the heart. It seeks out collateral channels, tiny escape valves that connect the portal venous system directly to the systemic K-valve circulation.
And one of the primary escape valves is the portosystemic anastomosis located at the distal esophagus. The high-pressure portal blood backs up into the left gastric vein, which flows directly into the tiny, delicate submucosal venous plexi of the lower esophagus.
These veins were evolved to handle a tiny trickle of local blood. not the massive pressurized output of the entire gut.
Consequently, the veins engorge, dilate massively, and become tortuous. These are the varices. Grossly, if you perform an endoscopy, they look like enormous, bulging, blue, snaking vessels protruding directly into the esophageal lumen.
The clinical logic here is terrifying. They are completely asymptomatic. The patient has no idea they're there, but they are sitting right beneath a very thin layer of squamous mucosa. If the pressure gets too high, or the patient swallows something sharp or retches violently,
A varix ruptures. And because it is directly connected to the pressurized portal system, it leads to massive, explosive, life-threatening hematemesis, vomiting profound amounts of bright red blood. It is an absolute catastrophic medical emergency. Despite modern band ligation and pharmacological interventions, up to 30% of patients die during their first variceal hemorrhage.
moving from vascular explosions to mechanical tearing, we have Mallory Weiss tears.
These are longitudinal mucosal tears crossing the gastroesophageal junction. The pathogenesis here is purely mechanical. It is caused by severe retching or prolonged vomiting, classically seen in the context of acute alcohol intoxication or bulimia.
Normally when you vomit, your body coordinates a complex reflex. The diaphragm contracts, the abdominal muscles squeeze the stomach, but crucially the lower esophageal sphincter relaxes to let the contents fly out.
But during prolonged, violent retching, that delicate reflex arc fails. The stomach forcefully and violently expels its contents upward, but the sphincter remains tightly closed. The massive spike in intragastric pressure stretches the mucosal wall of the distal esophagus until it physically rips apart.
These are superficial tears. They usually present with painful hematemesis after a bout of severe vomiting. They typically heal on their own with supportive care. You have to contrast this with Borhave's syndrome, which is a full-thickness transmural rupture of the esophagus. In Borhave, the stomach contents blast through the esophageal wall directly into the chest cavity, causing severe mediastinitis and sepsis, requiring immediate emergency surgery.
Now let's look at the cellular lining itself. Inflammation of the esophagus is termed esophagitis. The esophageal lining is non-keratinized squamous mucosa, functionally very similar to the inside of the cheek. So it faces similar threats. Let's run through the infectious pathogen lineup.
This is a classic matching question on the boards. Infectious esophagitis is relatively rare in healthy individuals. It is almost exclusively seen in immunosuppressed or debilitated patients. Think advanced HIV, organ transplants, or severe chemotherapy.
Let's start with the fungus, Candida esophagitis. Endoscopically, you see adherent gray-white pseudomembranes coating the esophageal wall. Histologically, if you biopsy it and use a silver stain, you see densely matted fungal pseudohyphae physically invading the superficial layers of the squamous mucosa.
Now for the viruses. The exam will force you to distinguish HSV esophagitis from CMV esophagitis based on microscopic findings.
Endoscopically, herpes simplex virus, HSV, typically produces distinct punched-out ulcers. To diagnose it, the pathologist must look at the squamous epithelial cells at the edge of the ulcer. Inside those degenerating squamous cells, you will see the classic viral cytopathic effects: multinucleation, ballooning, and exclusively nuclear viral inclusions.
HSV punches out ulcers and only attacks the nucleus of the squamous cells. What about CMV cytomegalovirus?
Endoscopically, CMV causes shallower linear ulcerations. But microscopically, the tropism is entirely different. CMV doesn't infect the squamous cells at the edge. It infects the endothelial cells of the blood vessels and the stromal fibroblasts at the base of the ulcer. And inside those cells, CMV produces massive owl's eye inclusions that are located in both the nucleus and the cytoplasm.
That is a phenomenal differential. HSV punched out ulcers, squamous cells at the edge, nuclear inclusions only, CMV shallow ulcers, endothelial cells at the base, nuclear A&D cytoplasmic inclusions. Lock that in.
Now, the most common cause of esophagitis in the general population isn't a fungus or a virus, it's a chemical burn. Specifically, reflex esophagitis, which is the pathologic tissue damage caused by GERD, gastroesophageal reflux disease.
The squamous epithelium of the esophagus is tough. It is highly resistant to the physical abrasion of swallowing tortilla chips, but it is chemically defenseless against acid.
Precisely. The stomach is lined with protective mucus to handle hydrochloric acid. The esophagus is not. The primary barrier is the lower esophageal sphincter, or LES. When LES tone decreases due to factors like central nervous system depressants, alcohol, tobacco, obesity increasing abdominal pressure, or a sliding hiatal hernia, the highly acidic, enzyme-rich gastric contents reflux upward into the lower esophagus.
It is a literal chemical burn occurring daily. What does this reflex damage look like on a pathology slide?
In mild early cases, you just see the tissue trying to regenerate faster than it's being burned. You see basal zone hyperplasia. The dividing basal cells make up more than 20% of the epithelial thickness, and an elongation of the lamina propria papillae stretching up toward the surface.
Yeah.
As the injury becomes chronic, inflammatory cells infiltrate the mucosa. First, you see scattered eosinophils. If the ulceration is severe, neutrophils arrive to clean up the necrotic debris.
Let me stop you there and push back. You just said GERD histology features eosinophils. But there's an entirely separate disease called eosinophilic esophagitis, or EOE. How does a student tell a slide of GERD apart from a slide of EOE if they both have eosinophils?
It is a matter of profound degree, anatomical location, and systemic clinical context. GERD has a few scattered eosinophils purely as a secondary reaction to acid injury, and it is localized strictly to the distal esophagus near the sphincter. Eosinophilic esophagitis, however, is a primary chronic immune-mediated disorder. It is essentially a severe allergic reaction of the entire esophageal tube driven by Th2 cytokines.
So on an EOE slide, you don't just see a few eosinophils. You see a massive, overwhelming epithelial infiltration. Pathologists look for greater than 15 eosinophils per high-power field, often clustering together to form microscopic eosinophilic microabscesses.
And critically, this intense eosinophilic infiltration can be found high up in the middle and proximal esophagus, far away from the acid reflux zone. Endoscopically, EOE is striking. The chronic inflammation causes the esophagus to form distinct, stacked, concentric, corrugated rings. We call it trachealization of the esophagus because it looks like a trachea.
The clinical logic is also entirely distinct. An EOE patient isn't usually an obese smoker with heartburn. It is typically a younger patient who is atopic. They have a documented allergic march history of asthma, eczema, or allergic rhinitis. Their chief complaint isn't burning, it's dysphagia and food impaction. They come to the ER because a piece of chicken is physically stuck in their ringed esophagus, and crucially, they are refractory to proton pump inhibitors.
Because PPIs suppress acid, they do absolutely nothing to stop a Th2-mediated allergic reaction to a food antigen. You treat EOE by identifying and eliminating the dietary allergen, or by having the patient swallow aerosolized topical corticosteroids to calm the immune response.
Let's go back to chronic GERD, because that daily acid bath doesn't just cause heartburn and basal hyperplasia, it drives the tissue to make a radical evolutionary adaptation. This brings us to the most important precursor lesion in the entire upper GI tract, Barrett esophagus.
Barrett esophagus is the classic example of metaplasia. The distal esophageal tissue is subjected to relentless chronic acid and bile reflux. The squamous epithelium is being destroyed. To survive, the local stem cells reprogram their differentiation pathway. They activate transcription factors like CDX2. The tissue essentially says, I cannot survive this acid as a squamous cell. I need to become a tissue that is designed to handle acid and bile.
So the pale pink multi-layered squamous mucosa is entirely replaced by a single layer of reddish velvety columnar mucosa. It mimics the intestines.
Yes, it undergoes intestinal metaplasia, and the absolute diagnostic hallmark, the single cell type that a pathologist must see on the biopsy to officially definitively diagnose Barrett esophagus, is the goblet cell.
Goblet cells. They are distinct, plump cells with massive mucin vacuoles shaped literally like a wine goblet. They secrete protective mucus. If you see goblet cells above the gastroesophageal junction, it is Barrett's. Why is this diagnosis so ominous? We found a way to survive the acid. Isn't that a good thing?
It's a temporary survival tactic with a massive biological cost. While the columnar cells handle acid better, they are operating in an environment they weren't designed for under constant inflammatory stress. Over time, these metaplastic cells acquire genetic mutations, most notably the loss of our old friend, the TP53 tumor suppressor. The tissue progresses from metaplasia to low-grade dysplasia to high-grade dysplasia, and finally it breaches the basement membrane.
It becomes invasive esophageal adenocarcinoma. Which brings us to the ultimate comparison for the esophagus, contrasting the two main types of cancer, adenocarcinoma versus squamous cell carcinoma.
Let's cement adenocarcinoma first. Because its entire pathogenesis is rooted in Barrett's esophagus, which is rooted in GERD, adenocarcinoma almost exclusively arises in the distal one-third of the esophagus, right near the stomach.
Epidemiologically, the incidence of adenocarcinoma is skyrocketing in Western nations. It directly parallels our rising rates of obesity and GED. Histologically, it looks like an intestinal tumor. It is a gland-forming, mucin-producing malignancy.
Now, contrast that completely with esophageal squamous cell carcinoma. This tumor does not arise from GER or Barrett's. It arises directly from the native original squamous epithelium. Because it doesn't rely on stomach acid, it typically occurs higher up, most commonly in the middle third of the esophagus.
The risk factors are entirely different. It is driven by chronic, severe mucosal irritation, the massive synergistic combination of alcohol abuse and smoking, or in some regions, dietary factors like drinking scalding hot tea that constantly burns the mucosa or caustic lye ingestion. Globally, squamous cell carcinoma is still the most common esophageal cancer, especially in rural areas of Asia and the Middle East.
Histologically, squamous cell carcinoma looks just like the oral SCC we discussed earlier. You see invasive nests of malignant squamous cells, intercellular bridges, and keratin pearls.
Clinically, however, both of these cancers share a terrifyingly insidious presentation. Patients don't feel them growing. By the time the tumor is large enough to cause symptoms, it is already massive. The classic presentation is progressive dysphagia.
The patient will tell you, 3 months ago I had trouble swallowing a piece of steak. A month ago I had to chew pasta into a liquid. Today I can't even swallow a glass of water without it getting stuck. This is the clinical hallmark of a mechanical obstructing mass growing into the lumen. It is accompanied by profound cachectic weight loss.
So, to differentiate them on a test, distal third tumor, history of GRD, gland-forming histology, adenocarcinoma, middle third tumor, history of smoking and heavy drinking, keratinizing histology, squamous cell carcinoma. Unfortunately, because the esophagus has a massive, incredibly rich submucosal lymphatic network, both of these cancers metastasize very early. Once the patient is symptomatic, the 5-year survival rates for both are notoriously dismal.
We have covered an immense landscape of pathology today. To ensure this information is locked in for exam day, we need to shift into our rapid review phase. Let's bulletproof the memory with high-yield mnemonics to solidify the most complex molecular pathways.
Let's do it. Expert, hit us with the mnemonics, starting with the viral sabotage of HPV.
For the HPV oncoproteins, remember the sequence: 6 before 7, P before R. The viral protein E6 attacks the cellular tumor suppressor P53. The viral protein E7 attacks the cellular tumor suppressor RB. 6 before 7, P before R. E6 hits P53, E7 hits RB. And remember, because RB is blocked, the cell panics and overexpresses P16, your diagnostic marker.
Brilliant. Next, the massive differential for salivary gland tumors.
The smaller the gland, the grimmer the stand. The parotid is the largest gland, so tumors there are overwhelmingly benign, like the pleomorphic adenoma. The sublingual and minor salivary glands are the smallest, so tumors there are overwhelmingly malignant, like the mucoepidermoid carcinoma. The smaller the gland, the grimmer the stand.
Finally, the viral esophagitis microscopic findings, the difference between HSV and CMV.
HSV punches. CMV is shallow. HSV causes punched-out ulcers, infects the squamous epithelial cells, and produces only nuclear inclusions. CMV causes shallow ulcers, infects the endothelial cells, and produces both nuclear and cytoplasmic inclusions, the classic owl's eye.
Perfect. Now, listener, let's put you on the wards. Let's test your differential diagnosis skills and diagnostic recall with 3 rapid case-style clinical scenarios. I'll read the case, try to lock in your diagnosis before the expert breaks it down. Here's the first scenario. Imagine you are in the clinic. A 45-year-old male with a 20-pack year smoking history presents with a distinct white patch on his inner cheek, the buccal mucosa. You take a tongue depressor and attempt to scrape it off, but it is firmly adherent. It does not scrape off. You take a punch biopsy. The histology report comes back showing orderly, thickened squamous epithelium with massive hyperkeratosis, but absolutely no dysplasia. What is the clinical diagnosis, and what is the critical follow-up logic?
The key physical exam finding here is the scrape test. Because the white plaque cannot be scraped off, you instantly rule out oral candidiasis, thrush. The clinical diagnosis is leukoplakia. Now, the biopsy shows no dysplasia right now, but the clinical logic for the exam is that leukoplakia is, by definition, a precancerous lesion associated with his smoking. Even without current dysplasia, this patient requires strict, continuous clinical surveillance because that hyperkeratotic tissue has a significant risk of transforming into squamous cell carcinoma in the future.
Exactly. Scenario 2. A 55-year-old female presents to your office complaining of a painless, slow-growing mobile mass just below her right earlobe. She says she first noticed it a year ago. You perform a surgical excision. The pathology report describes a biphasic tumor, epithelial cells forming distinct ducts, floating within a loose myxoid stroma that contains scattered islands of mature cartilage. What is the diagnosis?
Let's break down the anatomical and histologic clues. A mass below the right ear indicates it is located in the parotid gland. Applying the rule of gland size, a parotid mass is most likely benign. The histology is the absolute giveaway. It contains both epithelial ductal elements and mesenchymal cartilage elements. It is a biphasic or mixed tumor. The diagnosis is pleomorphic adenoma, the most common benign salivary gland tumor. The clinical pearl to remember is that the surgeon must ensure wide margins to remove all microscopic capsular extensions to prevent recurrence.
Spot on. Final scenario. A 60-year-old male with a documented 30-year history of severe alcohol abuse and heavy smoking presents to the emergency room with a 40-pound weight loss over the last 4 months. He reports progressive dysphagia. He states, "First, I couldn't swallow chicken, so I switched to soup. Now I can't even swallow water without throwing it back up." An upper endoscopy reveals a large ulcerated obstructing mass located precisely in the middle third of his esophagus. What is the diagnosis?
The patient's profound history of alcohol and tobacco use, combined with the anatomical location in the middle third of the esophagus, points directly away from GER-associated adenocarcinoma. The symptom of progressive dysphagia, starting with solids and progressing to liquids, is the classic presentation of a mechanical malignant obstruction. Integrating the location, the risk factors, and the presentation, the definitive diagnosis is esophageal squamous cell carcinoma.
That perfectly demonstrates how you must synthesize the patient's risk factors, the gross anatomy, and the clinical presentation to arrive at the correct pathologic diagnosis. We have made it to the end. You have officially survived the ultimate upper GI and oral pathology boot camp. We have traced the microscopic battleground from the lactic acid that melts your enamel through the viral sabotage of HPV, all the way down to the acid-burned metaplastic goblet cells of Barrett's esophagus.
But before we officially sign off, I want to leave you with a final thought to mull over. Something that extends beyond the rigid definitions of a textbook and into the philosophical reality of modern oncology.
Lay it on us.
Think back to our discussion on field cancerization in tobacco-associated oral squamous cell carcinomas. We established that if a patient's entire oral mucosa has been bathed in chemical carcinogens from cigarettes or chewing tobacco for decades, it generates multiple invisible independent mutant clones across the entire tissue field. Every cell is genetically scarred.
Right. It's not just one unlucky cell went rogue. The entire mucosal neighborhood has been corrupted by TP53 and RAS mutations, just waiting for the final trigger.
So the provocative question is this. If the entire microscopic field is genetically compromised, is surgical excision of a single visible tumor ever truly a cure? Or is the surgeon just hitting the first mole in a lifelong fatalistic game of molecular whack-a-mole?
Wow. Because even if you get perfectly clean surgical margins on that floor of mouth tumor, the normal-looking tissue an inch away on the tongue already has its tumor suppressors knocked out. It's just a matter of time.
Mercilessly, it challenges our entire localized anatomical approach to surgery. How might future immunotherapies or targeted gene therapies rewrite this paradigm? Can we develop treatments, perhaps a topical rinse or a systemic infusion, that don't just cut out the visible tumor, but actually reverse the invisible genetic damage, repairing the P53 pathways across the entire mucosal field before the next tumor even forms?
That is a brilliant, paradigm-shifting question to ponder as you review your notes tonight. It perfectly highlights how pathology isn't just about identifying what's dead on a glass slide. It's about understanding the living, evolving, highly dynamic landscape of human disease. Listener, you are going to absolutely crush this exam. Remember, the immense depth of knowledge you just gained, all these complex molecular pathways, the microbial shifts, the histologic markers, it isn't just for a board score. You are learning this to eventually recognize the subtle signs, to interpret the complex biopsies, and to make the critical calls that will save your future patients' lives. Keep that diagnostic X-ray machine of your mind sharp. Look past the murky waters of clinical symptoms and trust the pathologic logic you have built here today. Good luck, and keep diving deep.